Podcast 10 of the Thorax series. Clinical considerations of the thorax. This podcast will address a series of clinical considerations relating to the thorax and the thoracic viscera. So let's start off with the lungs and detail flail chest. So if a segment of the chest wall is damaged by multiple fractures in the same or adjacent ribs, then that segment can become mobile. And when the person undergoes inspiration or expiration, this segment is going to undergo paradoxical movement. And that means that this segment is going to move inwards with inspiration and outwards with expiration. This condition is known as flail chest, and it is very painful. It results in reduced lung ventilation and therefore reduced blood oxygenation. To prevent this paradoxical movement, pins or fine hooks are used to secure the loose segment and prevent it from moving. Further consequences of a rib fracture or other penetrating wounds, like a stab injury, can pierce the pleura that lines the inside of the thoracic wall. This would cause air to rush into the damaged pleural cavity and collapse the lung, and this is known as a pneumothorax. If the neighbouring intercostal blood vessels were also damaged, then blood can also collect into this pleural cavity, and this could be a hemothorax. So air into the pleural cavity is a pneumothorax, and blood into the pleural cavity is a hemothorax. A collection of fluid in the pleural cavity due to a lung or a pleural infection can lead to a hydrothorax. In some circumstances, a collection of both fluid and air can enter the pleural cavity during a stab wound, for example, and this can be known as a hemopneumothorax. To drain this fluid or air from the pleural cavity, then a chest drain is fitted. To carry out this procedure, a small incision is made in the mid-auxiliary line of the 5th or 6th intercostal space, which is roughly at the level of the nipples. To remove air from the pleural cavity, then the tube is usually directed superiorly, whilst to drain fluid, the tube is normally directed inferiorly towards the costodiaphragmatic recess. The end of the tube that is located outside the body, the so-called extracorporeal end, is connected to a draining system with controlled suction. This system is usually submerged under water to prevent air from re-entering the pleural cavity. Removal of air or fluid from the pleural cavity will usually result in the lung re-inflating. So flail chest, causing paradoxical movement of the chest wall with respiration, can also lead to a lung collapse via a pneumothorax, a hemothorax, or a hydrothorax. So now let's turn to some heart-related problems. If the pericardium that surrounds the heart becomes infected due to a viral, a bacterial, or fungal infection, then the pericardium can become inflamed, resulting in pericarditis. Clinically, this can cause severe chest pain, which radiates to the back and is usually relieved by asking the patient to lean forwards. Pain radiating from the chest to back region can sometimes be misdiagnosed as a myocardial infarction or a heart attack, but a reliable sign of pericarditis is a friction rub. This is when an extra heart sound is heard during auscultation. If the inflammation is severe, then fluid can leak from the pericardial capillaries, or pus can accumulate in the pericardial cavity, and this can result in a pericardial effusion, a collection of fluid within the pericardial cavity. If a large collection of fluid is present, then the increased intrapericardial pressure can lead to ventricular failure, as the ventricles are no longer able to fill with blood, and this causes blood to back up into the superior vena cava and the veins that drain the head. Compression of the ventricles by this increased intrapericardial pressure, and therefore a failure to eject ventricular blood, is a serious condition known as cardiac tamponade, and the fluid must be drained quickly. In order to aspirate or remove this excess fluid, a needle is inserted into the pericardial cavity and a pericardiocentesis is performed. This is when a needle is inserted through the anterior chest wall, either at the level of the 5th or 6th intercostal space, or alternatively via the infrasternal angle, and this is the space between the xiphoid process of the sternum and the costal cartilage of the 7th rib. A needle inserted in through the chest wall, through the pericardium and into the pericardial cavity allows this fluid to be removed and gives the opportunity for the ventricles to fill and expand with blood again, allowing ejection of ventricular blood. Okay, so now let's turn to a couple of congenital abnormalities that can form during development and are related to the heart. These are the septal defects and can be located in either the interatrial septum between the two atria or the interventricular septum between the two ventricles. An atrial septal defect usually results when the foramen ovale, which allowed blood to pass from the right atria to the left and bypass the pulmonary system during development, fails to close upon birth. In the newborn, this patent foramen ovale allows oxygenated blood returning to the left atrium from the lungs to move across the interatrial septum and enter the right atrium, and this is known as a left to right shunt, blood moving from the left atrium to the right atrium. With an intraatrial septal defect, a left to right shunt occurs due to the left side of the heart being under greater pressure as it's part of the systemic system, with the right side of the heart, part of the pulmonary system, being under lower pressure. The right atria will therefore receive increased levels of blood, which will overload both the right atria and ventricle, and this can lead to pulmonary hypertension, with the increased levels of blood increasing the blood pressure in the pulmonary system. If this condition is left untreated, then it can lead to right-sided hypertrophy, with the right ventricular wall increasing in thickness and ultimately resulting in heart failure. Septal defects can also occur in the intraventricular septum that separates the two ventricles. This condition is normally asymptomatic at birth, with symptoms being noticed a few weeks after, when a murmur is located upon auscultation and the baby is sweaty and breathes faster. With an intraventricular septal defect, blood will pass from the left ventricle to the right ventricle during ventricular systole. The amount of left to right shunting is dependent on the size of the defect. A small defect will lead to only a trickle of blood across the septum, and no symptoms will be present. If the defect is large, then as the heart enlarges and a significant pressure difference develops between the left and right ventricles, then blood will enter the right ventricle and pulmonary hypertension and right-sided hypertrophy will follow. So now let's have a look at the aorta, and I want to describe coarctation of the aorta, which also allows us to revisit several aspects of thoracic anatomy, including the aortic arch and the blood supply to the thorax. So a coarctation is the narrowing of the aorta, which is going to significantly reduce the blood flow down the descending aorta to supply the abdomen, the pelvis, and the lower limbs. To maintain the blood flow to these regions, then significant collateral circulations need to be developed to allow the blood to bypass the coarctation. Now, if you remember, running around the thoracic cavity in the intercostal spaces are the anterior and posterior intercostal arteries. The posterior intercostal arteries come from the descending aorta, and the anterior intercostal arteries come from the internal thoracic artery, which is a paired artery that originates from the left or the right subclavian and is positioned lateral to the sternum. So how does this collateral circulation develop? Well, because the aorta is narrowed, the blood pressure before the coarctation is going to increase, and this will force more blood to enter the free vessels which leave the aortic arch, proximal to the coarctation. This increased volume of blood will enter into both the subclavian and the common carotid arteries. Now we know that coming off each subclavian artery is an internal thoracic artery, which descends down the anterior chest wall and gives off the intercostal arteries. Because of the increased blood pressure in the aortic arch and its branches, the subclavian and the internal thoracic arteries increase in size to accommodate the increase in blood flow. As the internal thoracic arteries received increased levels of blood, so the anterior intercostal arteries will also receive an increased blood flow, and these form a collateral circulation by anastomosing with the posterior intercostal arteries. As the aorta will have a relatively low blood pressure distal or after the coarctation, then the blood from the anterior intercostal arteries can enter the aorta by running through the posterior intercostal arteries. The formation of this collateral circulation is vitally important in maintaining an adequate blood supply to the abdomen, pelvis, and lower limbs. An additional collateral circulation can also be established between the superior epigastric arteries, which are the terminal branches of the internal thoracic arteries. These will anastomose with the inferior epigastric arteries that are a branch of the external iliac artery, which supplies the lower limb. By forming this collateral circulation between the superior and inferior epigastric arteries, which then lead on to the external iliac, the lower limbs also receive adequate blood flow with an aortic coarctation. So to finish this podcast, I just want to look at the larynx briefly. Now the larynx is supplied by the left and right recurrent laryngeal nerves, which come from the two vagus nerves. If either of these nerves are damaged, then the person can develop hoarseness as the laryngeal muscles are paralysed. The most common nerve to be damaged is the left recurrent laryngeal nerve due to its location, and you should remember that the left recurrent laryngeal nerve comes off the vagus to run under the aortic arch and ascend towards the larynx, running in a groove between the trachea and the esophagus. Now, due to this position by the aortic arch, significant aortic aneurysms, where the wall of the aorta becomes disorganized and expanded, here the left recurrent laryngeal nerve can become compressed. It can also be compressed if the superior lobe of the left lung was to develop a tumour, which can press on the recurrent laryngeal nerve as it ascends towards the larynx. So this is the final podcast in the Thorax series. I hope you've enjoyed it, and the next series will look at the anatomy of the abdomen.